Good evening, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedius. I've done my MBBS from Father Muller College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. So today's topic is the anatomical and physiological differences between an adult and a neonate, the continuation of yesterday's topic. So proceeding, Unacademy is one of India's largest online learning platform where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. So guys, hurry and get your subscriptions. Now, what will you get out of Unacademy? So basically at Unacademy, we have our daily live classes. So we have basically when you go to a coaching institute, you have to get up, you have to get ready, you have to be there. It's a lot of effort, a lot of time waste, and once you get there too, you have to have an appropriate place to sit, and you have to be able to get the educators attention, and it's a lot of confusion that is happening, so it becomes a little difficult. Then even for the educator, it's a little difficult for your educator to clear everyone's doubts, because the educators, they are also time bound, they have to move on with the classes, so it becomes difficult overall. Whereas here in Unacademy, you can chat with your educator, engage in discussions, clear your doubts and answer polls, and all this is while the class is going on. Then we have our structured courses. So all our courses are structured and they are in line with the exam syllabus, and hence they help you best prepare. So the educators have researched, and whatever is needed for you all from Unacademy point of view, the classes are prepared. Then we have our live tests and quizzes. So we conduct live tests and quizzes. This will help you all to evaluate your preparation on a regular basis, and hence you all can get a detailed analysis on your performance. Then we have unlimited access. So one subscription can get you access to all our live and recorded courses, and you can watch from the comfort of any of your device. So wherever you all are sitting, whether you're at home or whether you are traveling, wherever you all are, if you all have access on the device, you all can easily access it. These are some of our top educators on the platform. Dr. Nikita Nanwani, she's a NEET PG mentor for radiology as well as mnemonics and concept, focusing on must-know topics encompassing all subjects. So now mnemonics is a very interesting part. If it is helpful for you all, it's really good, because if you all can prepare your own mnemonics, it will be even better for you all. But otherwise, her mnemonics too are really good, so you all can go through it. Dr. Mohammad Azam, Dr. Deepish Mishra, Dr. Preeti Sharma, these are also some of the top educators on the platform. Then we have the various courses offered. So as you can see, there are various subjects that you all have to cover. Almost 19 subjects you all have to study from NEET PG point of view. I know it's not easy, but we are here to help you all do precisely that, to clear this. So based on that, like subjects like anatomy, uh, radiology, psychiatry, anesthesia, dermatology, you'll never had to do much detail uh, right, you'll never had to go into much detail during MBBS. But here too, these are allotted 11 marks each. Okay, you all don't have to go into much detail here too, but the thing with this the thing here is, even though you all don't have to go into detail over here, the questions that they pose will not be that easy to answer without going through the basics of these subjects. So that's what we are here to do. We cover the basics that would be required for you all. So that's how we go about it. So if you all revise, study a little and all that, it will help you all. Then we have subjects like physiology, anatomy, pharmacology, pathology. These are like they require a year. So you need they have 44 marks each, and you'll have studied these for a year. So they can ask you anything from anywhere in this. So then these are some of the ongoing courses on our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, pathology, respiratory system, course on larynx. So these are the various courses on our platform uh, that you all can access. Then these are the 5 types of subscription as you can see on the screen. For those of you who are giving the exams, this year, your so there is so basically for the rest of you who you don't mind dropping a year and all that, the 6-12 months pictures, the 6-12 month 12 and 24-month courses are pretty decent. So they are more economical from the point of view that, see, after 6 months, in case you don't clear your exam, or something like that, like you don't like the subject that you get, then from that point of view, from that point of view uh, you know it's a waste of money, because you'll have to subscribe again if you you'll have to subscribe again if you want to access the videos or any recordings, or do the quizzes again or something. You'll have to pay again. So with the 12 and 24 months, you have that buffer period, of course. Then coming to the so the time that you actually take to prepare for this course, right? So it will actually be helpful for you to decide, and uh, for you to come to a conclusion of what you really want and what you really don't want. So it can be really helpful to you all from that point of view. What you all want, what you all don't want, you all can actually make up your mind in this 1 or 2 years. So as you can see, the 12-month subscription, if you use my code, you can avail a 10% discount. So this is the discount that you can avail. And for your 24 months, of course, there is another, you can use my code and avail the discount again. The discounts are, you can get a 10% discount by using my code. The discounts are applicable on all 5 subscriptions. 24 months, there's no harm in dropping 2 years. It's up to you, however you all are comfortable, whatever works for you all best. That's how you all should go about it. Nobody's going to ask you why you all took so long to clear, etc. Such questions nobody really cares, so go for it. So we just revised yesterday's what we did. So infant is a child up to 12 months, child is 1 to 12, adolescent 13 to 16, premature is less than 37 weeks, extremely premature less than 20 weeks. So airway wise, they have a larger head, short neck, short mandible, prominent occiput. The tongue is relatively large for the mouth, and there is absence of teeth, and hence easier to obstruct the airway. The neonates preferentially breathe through their nose. They are obligate nasal breathers. This is vital for respiration during feeding, and also the anatomy wise, it is because of the close proximity of the epiglottis to the soft palate. Mouth breathing occurs only during crying. Their narrow nasal passages can be easily blocked by secretions. Nasal mucosa is very, very thin and can be damaged by a nasogastric tube or a nasally placed endotracheal tube. 50% of airway resistance in neonate is from the nasal passages. The epiglottis is omega shaped, floppy, angulated away from the axis of the trachea, and adult epiglottis is broader. Okay. So this is the pediatric adult. Okay. So the thyroid separation is very close. There isn't the thyrohyoid distance isn't very much as compared to in adults. So that is one of the parameters that is monitored for a difficult airway in a adult, that is the thyrohyoid distance. Then vocal cords are concave in neonates and slant anteriorly, that is in adults it is horizontal. So in neonates the vocal cords are concave and slant anteriorly, in adults it is horizontal. Then airway and respiratory system, the larynx is high and anterior at the level of C4, C5. Adults, the larynx is at the level of C5, C6. The larynx is funnel shaped in a neonate. It is cylindrical in the adults. The narrowest level is at the subglottic area in the neonate, and ET tube may be too small to may be small enough to pass the vocal cords but not the cricoid area. In adults, the narrowest part is the vocal cords. The cricoid cartilage is circular and complete, and the tube nicely fits. There is no need to inflate the cuff. Laryngeal cartilages are soft and collapsible. So cuff inflation can lead to tracheal ischemia. Generally, cuff is not inflated. There should be some leak around the tracheal tube in neonates. However, now micro cuff tubes are available, which the cuff is designed in a specific manner. The material is very soft, which does not cause tracheal ischemia. So as you can see, in adults it is cylindrical, in neonates it is it is funnel shaped. Infants versus adult airway differences. So infants have narrow nostrils, newborns are obligate nasal breathers, occiput is rounded, tongue is relatively large for the mouth, epiglottis is omega shaped and floppy, larynx is higher in the neck, vocal cords slant anteriorly, neck is short, cricoid ring is the narrowest distance. So straight blades, Miller and Robertshaw are recommended generally. The straight blades are very helpful in neonates because in neonates there's little room to displace the tongue and the soft tissue forward. Larynx is higher in the neck. The chin is shorter. The neck is shorter and relatively large tongue. So curved blades like Mac are generally not recommended. Curved blades are designed to be placed between the epiglottis and the posterior pharyngeal wall in the space called vallicula. Curved blades cannot displace the tongue forward or lift the soft tissue and epiglottis up to see the larynx. So basically in a neonate, the soft tissue and epiglottis has to be lifted up to be able to see the larynx, and only the straight blade is able to do that. So the basically the in neonates, so in an adult the sniffing position is usually kept where there is flexion at the cervical spine and extension at the atlantoaxial joint. Okay, so this is a position that is used in adults for intubation because this aligns the axis. However, in a neonate the head needs to be kept straight in neutral position for ventilating the neonate. So as you can see, the sniffing position is flexion at the cervical spine and extension at the atlanto-occipital joint. Okay. However, in a neonate, this is to align the pharyngeal axis. So to align the pharyngeal axis, and the laryngeal axis will be aligned with the oral axis. So basically, all three axes in this the pharyngeal, laryngeal, and the oral axis, all three will be aligned in this position. In a neonate, however, to get this position, because too much extension cannot be done, so a small roll should be kept underneath the shoulder. Care should be taken to minimize trauma during laryngoscopy. Minimal edema can cause tracheal obstruction because the larynx and the trachea are so small. So, airway and respiratory system, 1 mm circumferential edema in an adult with a 10 mm trachea causes only a 44% decrease in cross-sectional area. So only a 1 mm circumferential edema in an adult with a 10 mm trachea causes only a 44% decrease in cross-sectional area. However, 1 mm circumferential edema in an infant with a 4 mm trachea causes a 75% decrease in area. The swelling from infections or trauma can have a very devastating effect, as you all can see in the diagram. So airway and respiratory system. The endotracheal tube diameter preferred for a neonate is around 3 mm, and the endotracheal tube for 0 to 6 months is 3.5, 6 to 12 months is 4. After that, it is basically, like I said, for less than 6 years, it is age in years plus divide by 3 plus 3.5, and more than 6 years is age in years uh, by 4 plus 4.5. Then an endotracheal tube must be inserted to the correct length so as to sit at least 170 to sit 1 centimeter above the carina, and be taped securely to prevent the tube from dislodging and or endotracheal intubation. Then for neonate, the preferred length is, so for neonate, the preferred length would be at 10 centimeters, for 1 to 2 years at 11 centimeters, and for for 1 year up to 11 centimeters, for 2 years 12 centimeters, and for children greater than 2 years at the level of lips. So age by 2 plus 12. So more than 2 years, age by 2 plus 12. Otherwise it is 10, 11 and 12. So age by 2 plus 12 for more than 2 years. Always verify endotracheal tube placement by auscultation. Sounds over infant chest and abdomen transmit very easily. Esophageal intubation can be missed if not cautious. So esophageal intubations can be missed if not cautious. First sign of esophageal intubation is hypoxia, bradycardia and potential cardiac arrest. So basically in an adult, the diaphragm and the intercostal muscles are very compliant, whereas the ribs and the diaphragm, intercostal muscles and chest wall is very compliant, and because of this they are not well supported by the surrounding structures like the ribs and the cartilages. So and also the diaphragm is not made up of the type 1 muscle fiber. They matures only by 2 years of age. Now the type 1 muscle fibers are the repetition fibers which help in repetitive activity. So because it is not mature, it becomes very difficult for the neonate to breathe. Okay, so it becomes a little difficult for the neonate to breathe in whenever there is any stress. Then horizontal, so it has they have a horizontal rib arrangement unlike the adult which has a bucket handle and hence helps in tidal volume. This because of the horizontal arrangement of ribs, the tidal volume is limited. uh, so to maintain ventilation, the infant depends primarily on the respiratory rate to maintain minute ventilation. It cannot depend The higher centers are, if it does not depend on the tidal volume, because tidal volume is unpredictable as we just saw. Higher centers are less responsive to various stimuli, unlike in adults. So maturation of lungs is complete by about 8 years of age. Surfactant starts at 24 days of gestation. By 28 weeks, surfactant with lipoprotein begins to appear. Lecithin and sphingomyelin ratio indicate fetal lung maturity. So more than 2 is low risk of respiratory distress syndrome. That is the lecithin and sphingomyelin ratio more than 2. Elastic tissue is poorly developed. So total lung capacity is 50 to 90 ml per kg. The neonate has limited respiratory reserve. So FRC is very less. This is the FRC is low in neonates. This is what helps to maintain, which prevents the fall in SpO2. So low in neonates. It is pretty low in neonates. Hence, apnea occurs very fast. SpO2 falls very fast whenever there is apnea. Then we have management is given CPAP and suctioning. So apneas are common post-operatively also in neonates, and apnea lasting longer than 15 seconds is associated with desaturation or bradycardia. So alveoli, the number and size increase till 8 years of age. So coming to the cardiovascular system. So in neonates, the myocardium is less contractile, causing the ventricles to. So the cardiovascular system, basically in neonates, the myocardium is less contractile and hence causing the ventricles to be less compliant. The ventricles are less compliant and are less able to generate tension during contraction. So this limits the size of stroke volume. So stroke volume is limited because the myocardium is less contractile, the ventricles are not compliant. So cardiac output depends entirely on the heart rate. Okay, so cardiac output is therefore rate dependent. The infant behaves as like an adult with a fixed stroke volume state. So it is difficult to maintain cardiac output in hypovolemia. Heart rate goes very high. Cardiac output is usually at 300 to 400 ml per kg per minute at birth and 200 ml per kg per minute within a few months. Cardiac output is around 300 to 400 ml per kg per minute. It's around 70 ml per kg per minute in an adult. Blood pressure at birth, the systolic blood pressure is 50 to 65 millimeter of mercury, and it reaches adult values by 12 years approximately. Then the parasympathetic tone is the tone which is predominant. So the parasympathetic tone is more dominant. So the sympathetic innervation is still incomplete. It's not yet complete, and adrenaline stores are inadequate. So there is poor control of the capacitance vessels. Baroreceptors are still inactive. So this makes neonates more prone to bradycardias because the sympathetic system, the compensating mechanisms are all very weak still, and whereas over here the parasympathetic tone is very prominent, so it makes them more susceptible to bradycardia. Now bradycardias ultimately will end up in a reduced cardiac output because the cardiac output depends on the heart rate. So any decrease, bradycardia, any decrease in heart rate ends up in reduced cardiac output or arrest. Okay. So bradycardia is associated with hypoxia, should be treated with 100% oxygen and ventilation. So bradycardia is associated with hypoxia. So any bradycardia associated with hypoxia should be treated with 100% ventilation, because again hypoxia, the ventilatory drive is not there in neonates, so it can be a deleterious effect at the end of it. External cardiac compression will be required in the neonate with a heart rate less than 60 beats per minute. So if the heart rate is less than 60 beats per minute, CPR will be required. So CPR should be given if the heart rate is less than 60 beats per minute. Immediately 100% oxygen and atropine of 0.02 milligram per kg. No response to chest compressions, then adrenaline of 5 to 10 microgram per kg can be given. So first, administer when the heart rate falls, administer oxygen and atropine. If there is no response, then proceed with the chest compressions and adrenaline. Give adrenaline. Most arrests due to hypoxemia or anesthetic overdose. So the anesthetic agents also depress the sympathetic system further, so there will be further bradycardia, right? So most arrests are due to hypoxemia or anesthetic overdose. Sinus arrhythmia is common. All other irregular rhythms are abnormal. So many profound changes occur. Many profound changes occur after birth. So the systemic vascular resistance doubles after the first breath. Pulmonary vasculature dilates. So the systemic vascular resistance will double after the first breath. The pulmonary vasculature will dilate, decreasing the peripheral vascular resistance. The systemic vascular resistance doubles after first breath. Pulmonary vasculature dilates. This will decrease the peripheral vascular resistance. Foramen ovale, which flows as left atrial. So basically at birth, because of the first breath, because of the oxygen, the systemic vascular resistance increases and pulmonary vasculature resistance will decrease, what is normally seen in vitro. The pulmonary vasculature will dilate, the foramen ovale will close as the left atrial pressure becomes higher than the right atrial. This is in the ductus arteriosus, preventing flow between the pulmonary artery and the aorta. Persistent fetal circulation can occur. Uh, so hypercarbia, hypoxia, acidosis can precipitate pulmonary vasoconstriction. It can because there is no oxygen. So oxygen is the one which decreases the pulmonary the pulmonary vascular resistance. So if this hypercarbia, hypoxia and acidosis are there, this pulmonary vasoconstriction can persist. If right atrial pressure exceed the left atrial pressure, the foramen ovale will remain open and the shunt will be exacerbated. If the ductus arteriosus fails to close, a right to left shunt may continue. And now the neonates basically present with this thing known as a flip-flop. This is very important. They have a something known as a flip-flop circulation. They have something known as a flip-flop circulation, which is basically, it is a transitional circulation. Okay, so the infant reverts from an adult type of circulation to the fetal type of circulation. Okay, so after birth it can revert from an adult type of circulation back to the fetal type of circulation. So the factors which lead to this are hypercapnia, hypercarbia, hypoxia, anesthesia-induced changes in the pulmonary vascular tone. So any anesthesia-related pulmonary vascular constriction can affect this balance. Okay, this flip-flop when this flip-flop circulation occurs, The pulmonary artery pressure increases. So the pulmonary artery pressure, same thing, it will increase to systemic level. So it will increase to systemic level. Blood is shunted past the lungs via the patent foramen ovale, and the ductus arteriosus may reopen and allow blood to shunt at the ductal level. So there will be flow between the pulmonary artery and the aorta, and so this persistent fetal circulation is also known as flip-flop circulation. So between the adult and the, it can suddenly revert back to this, it's known as flip-flop or transitional circulation. So after this, there will be a rapid downhill spiral may occur and lead to severe hypoxemia, which explains why hypoxemic events may be prolonged despite adequate pulmonary ventilation with 100% oxygenation. In most cases, simple hyperventilation will cause an increased pulmonary artery pressure to return to normal in response to a decreased arterial partial pressure of carbon dioxide. So the risk factors which can increase the prolongation of this persistent circulation are, so basically prematurity, infection, acidosis, aspiration pneumonia, hypothermia, aspiration, hypothermia, aspiration pneumonia, congenital heart disease. So these are all that can all are the risk factors that can lead to this flip-flop circulation. So the myocardial structure of the heart, particularly the volume of cellular mass devoted to contractility, is significantly less. We know that. So hence the heart rate is more dependent on the cardiac output. We know that already. Now coming to the musculoskeletal system. So the musculoskeletal system is uh, the bone growth occurs at different rates in different parts of the body. The bone growth will occur at different rates in different parts of the body. This affects anatomical landmarks. So midpoint is the length of is length on child. The midpoint in length on child is umbilicus. Adult is symphysis pubis, right? So for the child, the midpoint is umbilicus, and adult it is symphysis pubis. In the neonate, the imaginary line joining the iliac crest occurs at S1 in adults. So the imaginary line joining the iliac crest occurs at S1. Adult it is L4 or L5. Okay. So sacrum is not fused normally at birth. A birth spinal column has only the anterior. At birth, the spinal column has only the anterior curvature. Cervical and lumbar curvature begin with holding the head up and walking. So at birth, there is only the anterior curvature. The cervical and lumbar curvature will begin with holding head up and walking. Then renal system. The renal system, the renal blood flow, the renal blood flow, perfusion pressure, glomerular filtration and tubular functions are very low in the first 2 years of life due to a high renal vascular resistance. So at 20 weeks there is near complete maturation, and at 2 years of age there is complete maturation. GFR is low initially at 20 ml per minute. The tubular function is immature until 8 months, so infants are unable to excrete large sodium load and free water. So that's why in a lot of drugs, the dose adjustments have to be made. A lot of adjustment has to be made because these drugs can be, because of this immaturity, there will be prolongation of action of these drugs. Now, dehydration is poorly tolerated by infants. Premature infants have increased insensible losses as they have a large surface area relative to the weight. So, premature infants, there is increased loss as the surface area is large as compared to the weight. So, the weight is less in a premature infant, surface area is large. Urine output is around 1 to 2 ml per kg per hour. So half-life of medications excreted is prolonged, so longer interval for antibiotics. So the dosing interval has to be increased for antibiotics. Fluid turnover is 7 times greater than that of an adult. There is altered fluid balance. Organ perfusion and metabolism depend on adequate hydration. Infants and children are at a much higher risk for developing dehydration. Okay, so because of large surface area, etc., much this higher risk for developing dehydration. Now, the hepatic system. So, at term, the functional maturity of the liver is incomplete. Neonate liver is large. The most of the enzyme systems for drug metabolism are developed but not yet induced by the material that they metabolize. So most of the enzyme system exists but not been sensitized or induced by the material that they metabolize. So neonates rely on limited supply of, as the infant grows, the ability to metabolize medications rapidly increases for two reasons. So as the infant grows, the ability to metabolize medication increases because hepatic blood flow increases. The first reason is hepatic blood flow will increase. The hepatic blood flow increases and more drug is delivered to the liver. Enzyme systems develop and are induced. The second point is I don't know if there's something wrong with this. Anyways, the enzyme systems develop and the hepatic blood flow will increase. So because of these two, they get induced, they are developed and are induced, and the hepatic blood flow increases. For this reason, the enzymes start functioning. So the cytochrome P450 system is responsible for, so cytochrome P450. Okay. So the cytochrome P, okay, anyways, the cytochrome P450 system is responsible for the phase 1 metabolism of lipophilic compound. This system reaches approximately 50% of the adult value at birth. Um, okay. So phase 2 reactions involve conjugation which make the drug more water soluble to facilitate renal excretion. So phase 2 reactions are often impaired in neonates and result in jaundice and long drug half-lives. Some of these reactions do not achieve maturity until 1 year of age. So phase 1 and phase 2 reactions. Phase 1 is drug metabolism of lipophilic compounds. Phase 2 makes the drug more water soluble. So phase 1, at least there is 50% of adult values at birth, whereas your phase 2 is not developed. This is what leads to jaundice and all in the neonate. So plasma proteins are lower, greater levels of the free drug exist. The neonates rely on, so basically the neonates rely on a limited supply of stored fats. Glucogenesis is very deficient. So a preterm infant's liver has minimal glycogen stores and is unable to manage large protein load. So the preterm neonate cannot manage a large protein load. This accounts for the neonate's tendency towards hypoglycemia and acidemia and failure to gain weight when the diet contains too much protein. So that's why they develop hypoglycemia when the diet has too much protein, because they cannot metabolize protein, right? Plasma levels of albumin and other proteins necessary for binding drugs, are actually lower in the neonate and are even lower in preterm than in term infants. So this, with respect to coagulopathy, is very important, as well as for the binding other drugs and dynamic effects. So the lower albumin value, the less binding of some drugs, and will result in greater values of these drugs. Okay. In addition, the binding of sub-drugs to albumin may be altered in the presence of hypoalbuminemia in the neonatal period. So basically, liver function is initially immature with decreased function of hepatic enzymes, especially the phase 2, which makes the drug water soluble. Barbiturate and opioids have a longer duration of action due to slower metabolism. So barbiturates and opioids have a longer duration of action due to slower metabolism. So the GI system, the gastric pH and volume are close to adult range by the second day of life. Gastric pH is alkalotic at delivery. GERD, gastroesophageal reflux, is common until 5 months of age because of the inability to coordinate breathing and swallowing till then. That is why you have to go on burping the infant, right? They have a lot of GERD, and that's why a lot of colic and all up to 5 months of age, because of the inability. They cannot breathe and swallow at the same time. So upper GI vomiting and regurgitation, lower GI abdominal distension, and inability to produce meconium are common. So hypoglycemia is common in the stressed neonate, and glucose levels should be monitored regularly. Infants and older children maintain blood glucose better and rarely need glucose infusion. Hyperglycemia is usually iatrogenic. When hypoglycemia is in a neonate is less than 45 mg per deciliter, and it is treated with 5% dextrose in 0.2 to 0.9% sodium chloride maintenance solution. Hyperglycemia is 120 to 140 milligram per deciliter. Serum calcium is Serum calcium hypocalcemia is common in first 48 hours, 6.8 to 8 milligram per deciliter. Neonate heart is more dependent on calcium for contraction. This is important. It depends more on calcium for contraction. Hypocalcemia is very common, and hence it has to be corrected. Supplementation of 0.6 ml per kg of 10% calcium gluconate. So slow IV, slow infusion. So 0.6 ml per kg of 10% calcium gluconate. So 5% dextrose with 0.2 to 0.9% NS maintenance solution can be used. So hematology, at birth 70 to 90% of the hemoglobin molecules are hemoglobin F. Within 3 months, the levels of hemoglobin F drop to around 5% and hemoglobin A predominates. The hemoglobin levels drop over 3 to 6 months to 9 to 12 gram per deciliter as the circulating volume rapidly increases compared to the increase in bone marrow functions. So physiological anemia is common, and that is decreased erythropoietin. So physiological anemia is common, that is RBC lifespan is 70 days in a neonate, and in an adult it is 120 days. So the hemoglobin levels drop 3 to 6 months, drop over 3 to 6 months to 9 to 12 gram per deciliter as the circulating volume rapidly increases compared to the increase in bone marrow functions. So initially at birth, 70 to 90% of the hemoglobin molecules are fetal hemoglobin. Within 3 months, the hemoglobin F drops to around 5% and hemoglobin A predominates. The hemoglobin levels drop over 3 to 6 months to 9 to 12 gram per deciliter as the circulating volume increases compared to the increasing bone marrow functions. Physiological anemia is common because of decreased erythropoietin, and RBC lifespan is 70 days in a neonate and 120 days in an adult. The hemoglobin F combines more readily with oxygen but is then released less readily as there is less 2,3 DPG. So hemoglobin F combines more readily with oxygen but is then released readily as there is less 2,3 DPG. Uh, so the hemoglobin F combines more readily with oxygen but then it is less released as there is less 2,3 DPG. So though it combines with oxygen, it does not release the oxygen. So vitamin K dependent clotting factors like 2 2, 7, 9 and 10, and platelet function are deficient in the first few months. Vitamin K is given at birth to prevent hemorrhagic disease in the newborn. Transfusion is generally recommended when 15% of the circulating blood volume has been lost. Temperature control. So babies and infants have a large surface area to weight ratio with minimal subcutaneous fat and thin skin. So very little subcutaneous fat, large surface area to weight ratio. There's minimal subcutaneous fat and thin skin. They have poorly developed shivering and sweating and vasoconstrictor mechanisms. So these mechanisms to increase heat are poorly developed, like shivering, sweating, vasoconstriction. Brown fat is located in small amounts around the scapula, mediastinum, kidneys, adrenal glands, and metabolism is required for non-shivering thermogenesis. So brown fat metabolism brings about non-shivering thermogenesis. This is located around the scapula, mediastinum, kidneys, and adrenal glands. Okay, so it comprises 2 to 6% of neonatal body weight. More oxygen is required for metabolism of brown fat stores. So hypothermia is very poorly tolerated by the neonate for this reason because for non-shivering thermogenesis, basically this is brown fat metabolism is known as non-shivering thermogenesis right here. Non-shivering thermogenesis. So it is the more oxygen is required for it, and it comprises almost 2 to 6% of the neonatal body weight. Then they have so this shivering mechanism to increase body temperature is poorly developed, and they have the surface area to weight ratio is more. Uh, and they they have poorly developed shivering, sweating, and vasoconstriction mechanisms. Heat lost during anesthesia is mostly via radiation, but also may be lost by conduction, convection, and evaporation. The optimal ambient temperature to prevent heat loss is 34 degrees Celsius. So the optimal ambient temperature is 34 degrees Celsius in a premature infant and 32 degrees Celsius for neonates and 28 in adolescent and adults. So to prevent heat loss is 34 degrees Celsius to be maintained for a premature infant, 32 degrees Celsius to be maintained for neonates, and 28 in adolescent and adults. The low body temperature causes respiratory depression. So the hypothermia can cause respiratory depression, CNS depression, acidosis, decreased cardiac output, increases the duration of action of drugs, decreases platelet function, and increases the risk of infection. So entirely it is very deleterious, right? So it causes acidosis, CNS depression, cardiac depression, increased duration of action of drugs, depressed platelet function. So basically the baby is placed in a warming mattress, and head also. So the head, all those exposed areas of a child should be covered to prevent this heat loss that is seen in infants. So the blood volume at birth is 80 to 90 ml per kg. In 3 months to 1 year, it is 80 ml per kg, and more than 1 year, it is 70 ml per kg. That is adult values. So more than 70 ml per kg is adult values. Birth is it is 80 to 90 ml per kg. So maintenance of fluid intraoperatively, holiday cigar formula, 4 ml per kg for the first 10 kgs, 2 ml per kg for the next 10 kgs, and 1 ml per kg for every kg after. It does not include fluid deficit and third space loss. So if the weight of the child is 5 kgs, then 4 ml per kg for the first 10 kg. So 5 into 4, 20 ml of fluid has to be given in the first hour. So this will be a maintenance dose. This will be the maintenance dose. Then the deficit and so the fluid deficit has to be calculated separately, and the third space loss calculated separately and added to this. So third space loss is calculated depending on the operation, etc. So post-operatively 2 ml per kg for the first 10 kgs, 1 ml per kg for the next 10 kgs, and 0.5 ml kg for each kg above 20 kg. So 4 to 1 and 2 1.5. So neonates in the central nervous system, they can appreciate pain, and this is associated with an increased heart rate, blood pressure, and a neuroendocrine response. The blood-brain barrier is very poorly formed, and drugs such as barbiturates, opioids, antibiotics, bilirubin cross the blood-brain barrier easily, causing prolonged and variable duration of action. Narcotics depress the ventilatory response and cause a rise in the PaCO2. At birth, the brain is only 1/10 the body weight, and only 1/4 of the neuronal cells that exist in adult are present in the newborn. The neuromuscular junction is immature at birth and doesn't mature until 12 weeks. Acetylcholine sensitivity along whole length. Sensitivity to atracurium is increased, succinylcholine is decreased. Autonomic nervous system is developed at birth, though immature. Parasympathetic is intact and fully functional. CSF percent of body weight is greater and relatively high doses are required. CSF turnover is high. So the cerebral vessels in the preterm infant are thin-walled and fragile. They are prone to intraventricular hemorrhages. This intraventricular hemorrhage risk is increased with hypoxia, hypercarbia, hypernatremia, low hematocrit, awake airway manipulations, rapid bicarbonate administration, fluctuations in blood pressure and cerebral blood flow. So lower end of the cord is at L3 at birth and recedes to L1 by 1 year of age. This is the normal adult value. Lumbar puncture for subarachnoid block is L4, L5 or SL5, S1. Ligamentum flavum is much thinner. Psychology wise, infants less than 6 months of age are not usually, Infants less than 6 months of age are not usually upset by separation from their parents and will more easily accept a stranger. Children up to 4 years of age are upset by separation from their parents and the unfamiliar people and surroundings. It is difficult to rationalize with the child at this age. The behavior of this group is more unpredictable, and school age children are more upset by the surgical procedure, its mutilating effects, and the possibility of pain. Adolescents fear narcosis and pain, the loss of control, and the possibility of not being able to cope with illness. This is worsened by long periods of hospitalization. So today we dealt with the cardiovascular system. Basically, the cardiac output is dependent on the heart rate, as stroke volume is fixed due to immature contractility of the ventricles. The contractility is more dependent on calcium, and neonate calcium is they are more prone for hypocalcemia in the first 48 hours of life, and hence the serum calcium is always done at birth. Then also so that was around about the, the cardiovascular system. And then the neonates have a flip-flop circulation, so they can, when there's hypercarbia, acidosis, hypoxia, it can revert to the fetal circulation from the adult circulation. So there can be reversal of shunt from the right to the left. Shunting can be there, and this can worsen hypoxia. Musculoskeletal system, the midpoint is a pubic, in the child is the umbilicus, in the adults it is pubic symphysis. The spinal cord ends at L3 in an infant, and by about 1 year of age it reaches the adult value of L1. The spine at birth, the spinal column has only anterior curvature. The lumbar and the cervical are got by walking and getting up. The renal system is very immature until 2 years of life, and hence all the drug clearances will be affected. Newborns are more prone to dehydration and it is poorly tolerated by them, especially immature infants. They have altered fluid balance and organ perfusion. Hepatic systems is the cytochrome. The enzymes are not well developed. The neonatal liver is large. Glucogenesis is very poor, and hence they tolerate protein loads very less. So, because of the enzyme system, especially the phase 2 enzymes are not developed. At least the phase 1 enzymes, 50% of development is present, but it is still immature. So plasma proteins are lower and there's greater levels of free drug, and hence drug adjustments, dose adjustments have to be made. GI system, the gastric pH volume is reached by the second day of life. They are more prone to GERD up to 5 months of age because of the inability to coordinate breathing and swallowing, because metabolism we dealt. So the RBC lifespan is 70 days in a neonate as compared to the adult of 120 days. The fetal hemoglobin persists initially, and within the first three months, only 5% of HbF is present. HbA dominates, and the hemoglobin levels decrease to about 9. Physiological anemia is seen because of the rapid increase in the blood volume. The vitamin K dependent clotting factors are deficient at birth, and hence a vitamin K injection is usually given. Fetal hemoglobin usually binds oxygen but cannot release the oxygen. Temperature, they depend on the normal mechanisms of to control hypothermia, like shivering, vasoconstriction, sweating are poorly developed to control heat. So for hypothermia, they basically depend on brown fat for non-shivering thermogenesis. Brown fat for to produce non-shivering thermogenesis uses a lot of oxygen consumption. Fluids, birth blood volume is 80 to 90 and reaches the adult value by 1 year of life. Maintenance is the holiday cigar formula 4 to 1 rule, and post-operatively 2 1.5 for every 10 kg weight. Central nervous system, poor blood-brain barriers. Now, drugs can cross the blood-brain barrier and cause depression. Neuromuscular junction is immature until 12 weeks. Increased sensitivity to attract and decreased to succinylcholine. Parasympathetic system is more active. So guys, that's about it for today. See you all tomorrow. Have a good evening. Do use my code SASHA to avail your 10% discount. I shall see you all tomorrow. Have a good evening. Thank you.